So I hope my slides are visible.
Yes, Aarti.
Yeah. So good evening, everyone. At the outset, I would like to thank Dr. Sahu sir and Dr. Namrata Sharma ma'am for this wonderful opportunity. Big thank you to Dr. Boramanis sir for allowing me to present his topic of Dr. Boramanis Customized Incision Cataract Surgery. So as we know, cataract surgery has now become a refractive surgery, and the biggest concern with small incision cataract surgery is surgically induced astigmatism. So I will start with a scenario. This patient with preoperative astigmatism of 0.13 diopter underwent a small incision cataract surgery. Postoperatively, patient had astigmatism of just 0.17 diopters. So it is possible to not induce any astigmatism with CICS. So let me show you another case with pre-existing astigmatism of 2 diopter who happened to be a relative of optometrist and wanted to get implanted with autofocus pro lens, which is a multifocal lens without any rings. And presently they don't have any toric range of lenses. So other eye also had astigmatism of 2 diopter and phacoemulsification was done elsewhere. And the patient had same astigmatism of 2 diopters postoperatively. So we decided to do CICS for this eye with the aim of reducing the pre-existing astigmatism of 2 diopters. So patient underwent the surgery and postoperatively patient had astigmatism of just 0.43 diopters on topographer. Autoref showed the astigmatism of 0.25 and subjectively the patient was 6/9 with plano glasses. So the published literature shows that the biggest advantage of phaco over small incision cataract surgery is that the induced astigmatism is less. But there are no studies to say how small incision cataract surgery wound modification can lead to the desirable results on astigmatism. So the principle is very simple. A straight incision leads to astigmatism of 1.25 to 1.5 diopters. So when the incision is frowned, wherein the end of the incision goes away from the limbus, the astigmatism produced is 0.75 diopters, indicating that the more curved the incision is, the less astigmatism it will induce. So this is how one can titrate the incision against the pre-existing astigmatism. So after doing so many surgeries in last 5 to 6 years, Dr. Boramani says that a straight incision of 7 mm will induce astigmatism of 1.69 and it will keep on going down as the size of the incision is reduced. So if the incision is frowned 1, the induced astigmatism will be only of 0.5 diopter, and as you go on making it more curved, it will induce less astigmatism. If it is a perfect U-shaped incision, as in here, it will not induce any astigmatism. The temporal incisions are away from the optical axis, so they are not very strong in inducing or neutralizing the astigmatism. So a 7 mm temporal incision will induce astigmatism of 1 diopter, and a 5 mm will induce astigmatism of just 0.4 diopter. If the temporal incisions are curved, then they have no effect on astigmatism. Superonasal and superotemporal incisions behave in between the superior and temporal incisions, so accordingly you need to calculate. To have a better effect of incision on a steep meridian, you must center your incision on the steep axis, irrespective of the shape and the size of the meridian, so that the vector forces are acting equally from both the sides of the steep meridian. The next question is where to sit for the surgery. Whatever may be the steep meridian, you will always get this half circle on both the sides. So you can go inferotemporal or slightly superonasal. Operating from the nasal side may be difficult, but you can always fashion your incision on the steep axis. So the SIA software can be useful to calculate your own astigmatism. You can put one type of incision in one meridian to find out your own average astigmatism. So we will go through few more cases. This patient had preoperative astigmatism of 0.28 diopter and the steep meridian is at 100. The incision was taken at 100 degree and it was extremely curved. So there was hardly any change on the astigmatism. In this case, the left eye, the steep axis is at 40 degree. The incision was slightly curved, taken at superotemporal axis, and it had hardly changed the astigmatism. Next case where the astigmatism is 1 diopter and the axis is at 90. The incision was taken straight 6 mm and it had reduced the astigmatism. This is another case of multifocal IOL. 1.62 diopter of astigmatism has become 0.29 diopter post-operatively. This is an interesting case with astigmatism of 3.5 diopter and the patient was not willing to go for a toric lens due to financial reasons. A large straight incision was taken and there was a significant reduction in astigmatism and surgically induced astigmatism was almost 3 diopter. Her incision was almost 7.5 mm on the steep axis. This is another case wherein the pre-existing astigmatism of 3.3 diopter and the post-op astigmatism was just 0.5 diopters. So another case of multifocal IOL wherein the preoperative astigmatism of 0.33 diopter was reduced to just 0.3 diopter. Next case is of patient who was a doctor himself with preoperative astigmatism of 2 diopter and the steep meridian was at 170 degree in the left eye. And the patient was posted for a multifocal IOL. So the incision was fashioned at superotemporal quadrant and the astigmatism was totally neutralized. So this is his incision, left eye at 165 degree.
Superior nasal.
Yes, superior. So this is his refraction with the plano 6.6 and N5 vision. So now we can stop calling it surgically induced astigmatism and call it as surgically corrected astigmatism. And the technique should be called as customized incision cataract surgery. So it is better to mark all the patients with the technique you are comfortable with to avoid the error induced due to cyclotorsion when the patient is in the supine position. And then the axis can be marked intraoperatively using the axis marker. So to end my presentation with the customized tunnel engineering, it is possible to wipe out or at least minimize the stigma of astigmatism. Over to you, Boramanis sir, for your final comments on this presentation.